I prepared some cases, but as you know, we had a lot of slides for today. That's why I tried to decrease the number of cases and the slide. That's why I tried to speak in Spanish, even though my Spanish is not good, but it is my good experience, Dr. Ceredo. Do you want me to show several cases or stop here? You can decide, Dr. Gambo.
Well, Sophia, Santiago, I would like you to opine, please, or give your opinion. For me, I would like maybe one, if we have time for one. That's my opinion. Also, I would like to congratulate you, Dr. Song. I think it's fantastic that you tried to speak in Spanish, which is incredible. I think that's great.
Thanks to your help.
Yeah, but it was pretty good. Don't get me wrong. It was very good. For the first time that you're making a presentation in Spanish, I'm very impressed. So I think it's great that you're so brave.
Okay, Dr. Santiago Servio, do you want me to show you 3 cases?
Yes, I'd like to hear a few. Yes, I have time. I'd like to hear a few cases.
Dr. Gamboa?
Yes, I agree.
Okay, good. And first case, this is a patient with advanced gastric cancer. Here you can see almost a complete obstruction and ascites and widely patent stent. But the patient did not show improvement of symptoms even after stent placement. Why is that? Dr. Santiago Servio, what's your opinion? What's the reason of no improvement?
I'm looking. Maybe let me see the pictures.
This is a before and this is after.
I mean, I'm noticing like at least the radioscopy, it seems to be, there seems to be passage through the stomach, so there should be some improvements, but I'm not sure if the endoscopy, there is ingrowth into the stent, or maybe it needs to be bigger.
I have a question. Could it be maybe that there's a motility problem or a movement problem of the stomach? Maybe it's a stomach that is not advancing the food properly.
Yeah, that's a good idea. Why is that? But here you can see widely patent stent and good flow contrast medium from the stomach to the duodenum. But what about this area? Small bowel.
Yeah, exactly. Yeah, maybe a distal obstruction. Yeah, he has metastases, of course. Carcinomatosis.
Sure.
Many small obstructions in the intestine. Yeah, that could be it.
Yeah. So our previous data showed that the technical success rate was 99% and clinical success 83%. This is a report in 2004. We found out that the multiple small bowel obstruction due to carcinomatosis was a contraindication after this study. So that's why our prospective study in 2007 is better than the result. There is a clinical success rate was 94%. Okay. The second case, in this patient with pancreatic cancer with the liver metastasis, you can see widely patent stent, but 10 months after stent placement, follow endoscopic photograms and barium studies show narrowing of the stent lumen due to stent collapse. That's why we placed the second bare stent with a good result. But 4 months after the second bare stent placement, the patient visited the emergency room because of abdominal pain. And this is a chest PA obtained at the emergency room. What is the cause? And Dr. Sophia Gamboa, what's your opinion? What's the problem
I
with
think
this patient?
I think there was a stent migration maybe, and there was a perforation because in the radiography you can see a pneumoperitoneum.
Yeah, pneumoperitoneum. What is the cause? What would be the cause of
a perforation? Because of the stent.
You're right. So this is after our presentation. That's why we had only one patient with perforation. Abdominal CT shows the pneumoperitoneum and overlapped of 3 bare stents. In this patient, we placed 2 dual stents and 1 more stronger stent. So you can see upper end of the bare stent. So the patient subsequently underwent emergency surgery. Here you can see perforation of the duodenal bulb due to edge, the upper end of the stent. So because of the 3 bare nitinol stent wires overlapped at the upper ends, the hoop strength of the stent may have been increased. So we performed palliative gastrojejunostomy with the primary closure of the perforation after partial removal of the proximal stent. Actually, I joined the surgery because they didn't know how to handle the stent. So I tried to cut the stent with the use of a stent delivery system. You know that. So the patient died 13 months after surgery because of diffuse metastasis. This is very interesting case. Okay?
Yes, and doctor, I have a question, if it's possible.
Yes, please.
If there is a perforation, but it is not too big, you can place a cover stent and expect and not go to surgery?
Yeah, that's an idea, but actually, it was difficult for us to access from the mouth because that was a duodenal bulb. If it is, that's a good idea. If it is esophagus, of course, we can place the covered stent. But at the time, also the patient had a peritoneal sign. That's why the patient needed emergency surgery because of the peritonitis.
Okay. Yes.
Finally.
I have a question there because yes, that sounds like a good idea. What happens if you could have been able to put, and the patient did not have peritoneal signs? Would a covered stent have been a good idea when you already had 3 stents placed? Wouldn't a 4th stent cause even more pressure? Wouldn't it?
Yeah, that's a good question. That's why theoretically and practically it's impossible to place the stent through the mouth into the duodenum. But if you want to place the stent, it should be a covered stent. So unfortunately, this is not retrievable stent. That's why for the patient with esophagus, we routinely perform retrievable stent placement. In case of complication, we can remove the stent, but this is not retrievable stent. So it is difficult to remove the stent. Also, it is difficult to place another stent outside the obstruction or perforation. There's a limitation. That's why the retrievable stent is better than unretrievable stent. But you can have a new idea to solve this kind of problem because you are a surgeon, you have a lot of advantage. But there is a limitation for myself. Okay, last case. In this patient with unresectable pancreatic cancer, here you can see a long stricture from the duodenal bulb to the post part of the duodenum. Do you think it's indication for stent placement? Dr. Celedon, what's your opinion?
Wow. as a surgeon, I would say no. I would say no, we're too late. Probably I would think that it's a completely palliative case, and I would consider a gastrojejunostomy because I would think that there's not a stent long enough for such a long stenosis. But I don't know.
So you prepare gastrojejunostomy palliative, right? And then Dr. Servio, what's your opinion?
Yes, if I agree with the stent placement.
Do you want?
The connection is a bit.
Okay. Okay, this is a final case. I'll show you. Anyway, the patient needed a stent placement. So we placed the 2 stent overlapped with the first one. So that was the longest stent I have ever placed. So we placed the stent from the gastric outlet to the fourth part of the duodenum. Here you can see probe contrast medium. But our data in 40 patients, it was not that good, even though the technical success rate was 100%. Clinical success was 65 patients, even though we excluded patients with the peritoneal carcinomatosis. So the independent predictor of poor clinical success were metastatic cancer and external cooperative oncology group ECOG score more than 3 and the carcinomatosis with ascites. But anyway, it's not contraindication, but you should be careful in selection of the cases. Okay?
I'm impressed with that last one. That's very interesting. But you placed 2 dual stents.
Yes, 2 stents. And
so you overlapped the
yes, at the end.
The ends. Okay.
Mm-hmm.
Well, interesting. And did you know the cause of the stenosis? Did you know was it tumor? Was it many parts tumor? Was that carcinomatosis?
Excuse me.
What was the cause of such a long stenosis?
That is a duodenal invasion from the pancreatic cancer. It involves all parts, not carcinomatosis.
Not carcinomatosis.
That is a retroperitoneum, right? The duodenum.
Yes. Okay.
So a direct invasion from the pancreatic cancer.
Very interesting. You would have expected maybe some sort of pain or some sort of like the feeling of the stent in there. It's such a long stent. They must have felt something.
Sure. Also, because the stent is long, the passage is not that good. So you should be careful in selection of the patient because the patient can cause pain.
Yes. Okay.
Okay. Dr. Gamboa?
Yes, I have a question. Did you have good results placing 2 stents in that case?
Yes.
With a long stenosis?
Yes. Even in esophagus, we can place the stent, 2 stent with a slight overlap at the end because sometimes the patient has a very long and diffuse stricture from the beginning of the thoracic esophagus to the end of the esophagus. In the case, we need 2. Sometimes 3 is possible, but as I mentioned, if the stricture is long, the result is not good.
Okay. And how much time you can leave the stent and the patients have clinical or they were good?
Yeah.
How many time?
For the patient with inoperable cancer, we place the stent and perform chemotherapy. But regarding the esophageal cancer, we can remove the stent 4 weeks after starting chemotherapy. But regarding the gastric cancer, we cannot remove the stent. That's why we leave the stent there. But as I mentioned, in 4% of the patient, the stent migrate even after chemotherapy. Yes. So if we can design the retrievable stent for gastroduodenal stent, that will be much better than the dual stent.
Okay.
But you can design new devices. Yeah, you can make it because I taught you everything regarding the stent. Okay, thank you very much for your attention and cooperation.
Okay. Bueno, muchas gracias entonces a todos. Gracias a Sofía, a Santiago y pues a todos los demás que podrían estar escuchando. Muchas gracias. Thank you, Dr. Song. Muchas gracias a todos. We're going to see each other next week. Próxima semana nos vemos. Muchas gracias a todos. Que pasen muy buenas noches.
Okay, thank you.
Bye.
All right.
Thank you very much.
Okay. A 64-year-old man with penetrating abdominal trauma underwent emergency operations 3 times in a week because of like a bleeding control and jejuno-jejunostomy and a small bowel resection 150 cm long with entero-enteric anastomoses for treatment of intra-abdominal bleeding, duodenal disruption, and multiple bowel perforations. Here you can see the hematoma, particularly in less sac, and also in the peritoneum, and also in the pelvic cavity. And then the patient was transported to SM Medical Center. So in SM Medical Center, the patient underwent emergency surgery, including repair of jejuno-jejunostomy, multiple entero-enteric anastomosis, and feeding jejunostomy. Because of disruption of the duodenal-jejunostomy, multiple entero-enteric anastomosis failure, and bile-peritonitis. So it was impossible to close the abdominal wall defect with the muscle flap. This is 7 months after the surgery in SM Medical Center. Not only because persistent bile leakage through the defect, here you can see bile, but also because of severe retraction of the end of disrupted duodenum. This is a feeding tube into the jejunum. And then there were 3 access from the abdominal defect to going to the gut. The one going to the jejunum. This is exactly the same course of jejunostomy for feeding, and another access reaching the duodenum, and the other one going to the duodenal bulb and stomach. So there were 3 access routes. Question: how would you treat the patient? Dr. Ceredon, do you have any idea?
I have no idea. We as surgeons, we see these type of patients sometimes, and they're absolute disasters. They're like the worst thing you can imagine for somebody, and you want to help them so much. But this is so complex. It's so difficult. And I'm surprised that you were able to do this type of fistulography, where you were able to find exactly what part of the intestine you're in and which direction you're going in. That's that's the first step for me, I think. And but I think we never even get to this point. Recently, I'm trying, because I'm doing more radiological studies, I'm trying to get more into these type of steps, like, well, okay, let's start, let's try and see what we can see with fluoroscopy. But after this, I have no idea what would be the next step. I don't know.
Yeah, exact information is important
Yes.
for treatment. Dr. Sofia Gamboa, what's your opinion?
Maybe you can leave the catheters. At the minimum 7 days, but then more and wait to create a fistula. And after having the fistula, maybe you can see how to close. There are, if the bile or I don't know how to say.
Pancreatic juice.
Yes, the pancreatic juice is less than 500. Maybe you can expect that close itself.
I would like to say something there, because this is what you expect or what you hope can happen.
Yeah, yes, of course.
But I'm telling you that from my experience, this does not happen. Once they have the established fistula tract, it doesn't matter if you put a catheter or not. The body doesn't fistulize it. It doesn't close around it. It just has the tract already made. So, for example, that's my experience. Whenever I've tried it like twice recently after I came back from Argentina. I've tried to do that, put a catheter, and maybe it might help to fistulize it. It doesn't help at all. From what I've learned, from what I've seen, I think we should be thinking about doing some sort of maybe I think like Sophia, I would think also that we would have to want to control the fistula, putting the catheter in there, and then maybe using the catheter, we could, I don't know, maybe using the catheter, we can maybe put some sort of treatment to collapse the fistula or something like that. But that we have not done that. We just tried, and then the body doesn't I don't know, it doesn't close around it. It doesn't feel that it's a fistula. It already established its tract, so it doesn't care about whatever you do with it. I think that's my opinion.
Okay, Sophia, please.
No, that we have a case of a girl, 21 years, that she had a surgery because of gynecologic pathology, but she have an injury in the jejunum, the proximal jejunum. It was very, very proximal. So she started having a lot of bile. Of bile. So she had many surgeries, at least 3-4 surgeries, but at the end we used a bag. We tried with a bag.
Bile
I
don't
know if you know, Manuel, bag. The vacuum assisted closure.
Exactly.
Vacuum assisted closure is a device that uses negative pressure and sponges. In a vacuum, to maybe to close and reduce the edema of the intestines and maybe fistulize all the liquid outside of the cavity. It's a system that we also use here. Yeah.
Yes, we try with the bag, but she has a less debit, less bile. But at the end, we stop using the bag, and then she closed itself. We couldn't believe it. Yes,
okay.
It was.
But here you can see the abdominal defect is quite big. And then this is a 8 months old abdominal defect. But anyway, I'll show you what we have done. So on endoscopic, gastroenterologist performed endoscopic nasobiliary drainage to divert the bile, and also endoscopic nasopancreatic drainage to divert the pancreatic juice. And I placed a stent through the mouth with the proximal end in the duodenal bulb and distal end in the jejunum, because the patient underwent duodenal-jejunostomy. So the initial result was good, but you can see this is after stent placement, but 5 days after stent placement, the stent migrated downward. So it was not difficult to remove the migrated stent through the skin defect, abdominal defect. And then after stent removal, we placed a long stent. The first one was 9 cm long, but second one is 13 cm long from the gastric enterium to the jejunum. And 5 days after second stent placement, a surgeon performed closure of the abdominal defect with the use of the muscle flap here. And then 3 months after gastric stent placement, here you can see a widely patent stent and granulation tissue formation at the upper end of the stent, but the patient was able to eat food through the mouth. And then we removed the stent 3 months after stent placement. You can see a small fistula and the abdominal tract, but improvement of contrast leakage. So here you can see before stent placement, after stent placement muscle flap. This is 5 months after muscle flap. So the patient was able to take food orally after and before stent placement and stent removal with a complete healing of the abdominal wall defect, except for small enterocutaneous fistula. That was 2012. And I heard that the surgeon followed up the patient and complete closure of the abdominal defect. So that was a result of collaboration between surgeon, interventional radiologist, and gastroenterologist. So that collaboration saved the patient. Any questions or comments regarding this case?
Yeah, like a million, but I'll probably ask a couple. During the time that you did the biliary diversion and the pancreatic diversion, was the patient was on parenteral nutrition, I'm guessing?
Yes, during that time, yes.
How
not parenteral. The patient had jejuno-stomy tube, so it was helpful for the time being. And then we removed everything because the patient was able to eat through the mouth. So after, you can see, after this one, we removed it, yes. So and then the patient needed a hypoparenteral alimentation, yes.
Okay, so you remove the biliary, the bile production and the pancreatic production, but you have all the gastric production of gastric juices, and you have all the saliva production. So the patient still had a lot of fluid going through the intestine or through the fistula.
But here you can see the patient was able to eat through his mouth. So here you can see still the nasobiliary tube to drain the bile juice through the tube, and then also pancreatic juice through the nose.
You think that these two juices in particular might be very caustic, might have promoted that the fistula remain open? Is that what you were guessing?
Yes, I believe so. But anyway, it was evacuated, drained through the nasogastric tube.
Wow. Okay. And was it by any chance like placed into the jejunum of the patient again so he could digest the food, or no, he was just losing all that liquid outside?
Yeah, it's possible, of course, yes. But there could be different kind of technique. Here you can see the patient still has some catheters even after a stent removal.
Impressive.
Aggressive.
No, not aggressive. Impressive. Impressive.
Yes. Okay. Anyway, I will show you the second case. This is also very interesting case. A 78-year-old male patient received chemoradiation therapy for pancreas tumor for 2 months in 2000. Here you can see pancreas tumor involving the left upper lung. And then the patient visited the hospital due to the dysphagia to solid food for 3 weeks, 1.5 years after chemoradiation therapy because of the regrowing of the pancreas tumor. So the endoscope, here you can see barium study shows narrowing at the proximal part of thoracic esophagus due to extrinsic compression by the regrowing mass. The question, what would you do for this patient? Sophia?
I think I would place a stent in the stricture.
Okay. And Dr. Celedon?
Well, it was because of like recurrence of the pancreas tumor. So yeah, it sounds like it could be due to the tumor, but also the patient received therapy, received some sort of treatment. Did he receive radiotherapy? Yes, I understood that.
Yeah.
So it could also be a stenosis due to, it could be stenosis due to the radiotherapy. Did you do an endoscopy?
Yes. Actually, this was not due to radiation therapy. Usually, the radiation fibrosis occurs 2 or 4 months after radiation therapy. Also, the findings are different. Okay. The mucosa was okay endoscopically and also for radiologically, just extrinsic compression here. Okay. So also the patient didn't have any dysphagia for the almost 1 year, 13 months or 15 months after chemoradiation therapy. So, okay.
Yeah, I think then in that case, if it's due to the recurrence of the tumor,
yes,
I think I think Sophia's right. A stent might be the best way. Yeah.
So this is our policy. Most of the doctors, they prefer stent placement at this time of the stage because of the dysphagia to solid food. But my policy is different. When the patient can swallow soft food without dysphagia, I don't like to place the stent. And also I ask the patient to chew food thoroughly because a stent placement can cause complications. So anyway, I ask the patient to try to eat soft food. And if there was any progression, please visit us again. That was my recommendation. But anyway, 1 month later, the patient visited the hospital saying that there was aggravation. Here you can see aggravation of the narrowing due to the regrowing of the mass. So one of my colleagues placed a 7th generation's esophageal stent with a good result. And here you can see a little bit narrowing of the trachea due to the mass, not a stent. Also, before and after stent placement, there is a slight compression, but the patient didn't have dyspnea at the time. This is just after stent placement. Here you can see good flow of contrast medium. The stent is not fully expanded because that is just after stent placement. this is a one-day follow-up esophagram showing expansion of the stent and good flow of contrast medium. The patient complained of dyspnea 15 days after stent placement. So my colleague believed that the dyspnea was due to the compression of the trachea due to expanded stent, because the stent expanded more and more, almost the fully expanded diameter. What's your opinion? What was the cause of this dyspnea? And I'm sorry, I have to explain one. And then my colleague said that the stent was very reluctant to be removed. But anyway, he grasped the nylon drawstring and then pulled it over. But there is still the proximal end of the stent was not completely collapsed. So even though it was reluctant, he just removed it. And then he found out that a polypoid mass in the proximal end of the stent, and the patient was sent to the ICU because of hematemesis after stent removal. So the patient and his family members denied embolization or surgery because the terminal case. And then again, my question, what were the causes of dyspnea and bleeding? Dr. Celedon?
I'm guessing that the pancreas tumor in some way probably could have invaded the trachea or the esophagus. I'm guessing
esophagus?
Yeah.
And any other guess?
Polypoid. Does he have some sort of maybe a Senker diverticular or something like that, or not something strange or that wasn't seen? No.
Okay. Anyway, let's review this one. You remember this study just after stent placement? This is 1 day after stent placement. Anything wrong?
Anything wrong? Well,
that is expanded.
Yeah, I'm trying to see if there's something that we didn't see. Up here in the proximal part, does it see any defects or filling defects? Yeah.
Yes. What's that? Filling defect here.
Yeah, something like that.
So we reviewed this case together. Also, I joined the case. And then we reviewed all the films. And this is just after stent placement. There was something like a stalk here.
Yeah.
And a filling defect. And then also above the stent, 1 day after stent placement, there should be a filling defect. But my colleague said that that was air, but it's not possible. Air is too round and also constant. And then also I reviewed the stent removal case again. That was very strange because here you can see complete expansion, and then it did not collapse. It was very rare and eccentric. And also it was not clear, but there was something in the proximal end of the stent overlapped with trachea and here constantly. And then I reviewed all the esophagram 1 day after stent placement. Again, this is clear. A filling defect moving up and down to the proximal end of the stent, right? You can see inside and then outside, the outside, and then it moving down and up. So I believe that was a polypoid mass. So we reviewed all the chart And I met the patient family members. They said that the patient had polypoid mass and proximal esophagus, but we didn't know that. That's why when it passed, moving down into the proximal end, he just grasped the nylon drawstring. So it was removed, captured by the stent. That's why it was there was a hematemesis. So here you can see this is a plain radiograph, scout film during stent placement and stent removal. Here you can see stent is still there. And then before stent placement, there was no pneumonia. But here you can see pneumonic infiltration on both lower lung field due to aspiration pneumonia. So that was due to aspiration due to the sometimes obstruction of the proximal end of the stent, and then the patient enjoyed eating. That's why there's aspiration pneumonia. So this kind of thing can happen because of the ignorance. So it is very important to review all the data and images, because this happening was due to ignorance and it could have been avoided. That was our learning from the patient. Any comment or question on this case?
Doctor, I have a question.
Mm-hmm.
What was the way you used to place the stent before you saw that image in the radiograph?
What do you mean?
Yes, when you place the stent, it was fluoroscopic or endoscopic? Because it was endoscopic, I think you have...
Oh, that's, I see. Good question. That was a fluoroscopic stent placement. My colleague placed the stent fluoroscopically. When we perform fluoroscopic stent placement, is 100% under fluoroscopic guidance, not endoscopic guidance. And that's a good question. Mm-hmm.
Because if it was endoscopic, then you should maybe see the polypoid mass, no?
Sure. So even though the patient had a polypoid mass in the cervical esophagus, it's a good indication for stent placement because the obstruction was at this part. The polyp should be around here, right? So we had to give advice to the patient. As you have a polypoid mass, please try to eat food thoroughly, and then try to have water after or liquid after having solid food. In the case, it can prevent aspiration pneumonia.
Okay.
Okay. Any other questions or comment? That's a good question.
Thank you.
If not, do you want show you some more case?
Yes, I think
you have time?
Yes, I have time for one more.
Okay, one more. Okay, I'll show you just one more. Oh, okay. A 53-year-old woman have had epiphora and intermittent cystitis for 15 years. This is a plain radiograph. And what's your diagnosis? And what is the next study? And how would you treat? This is not GI disease, but very interesting case. So if you don't have time, we can skip this one. If you are interested, I will move on to. Dr. Seredon.
I like it. I think it's interesting.
Okay.
This is probably a damage or a dysfunction of the lacrimal duct. I'm guessing that this this image on the plain radiograph or on the maybe it's a Waters or something like that. It's it does seem to find a radio opaque like nodule up there, you know. So it could be for an object, or it could be maybe some sort of small tumor, bone, or something like that. I'm guessing.
Calcified tumor. This is radio opaque,
like that. Yeah.
Okay.
What would be the next study? I would say a CT.
Okay, CT, good idea.
And how would I treat? I don't know. I don't know that yet.
Okay, Dr. Sofia Gamboa, what's your opinion? What's your diagnosis?
I agree with Manuel. I think there is an obstruction. I don't know the region, but I think there is an obstruction, and the best way to see what is the cause, I think, is the CT. Okay, good. Anyway, the lacrimal drainage system includes the superior and inferior punctum, superior and inferior canalicularis, common canalicularis, and lacrimal sac, and nasolacrimal duct. The nasolacrimal duct extends from the inferior portion of the lacrimal sac through the bony canal into the inferior meatus of the nasal cavity. So there are many mucosal folds, and the most popular one is at the end of the nasolacrimal duct, which is termed valve of Hassner, and then between the lacrimal sac and nasolacrimal duct is a valve of Krause. And we performed bilateral subtraction decryocystography because the patient had epiphora. Here you can see obstruction at the junction between the lacrimal sac and the nasolacrimal duct and marked dilation of the lacrimal sac. When there is an obstruction, drainage of tears into the inferior meatus is not sufficient. So the tears fall of the lid margin onto the cheek, which is called epiphora. Epiphora is a very annoying disability because the patient has to frequently dab the tears with a tissue or handkerchief. In addition, chronic decrocystitis and eczematous condition can be produced. And I developed the lacrimal stent for the first time, so it was popular. It was produced by the Cook, but anyway, we placed the stent, and then the filling defect was disappeared. What happened? That's very interesting, right? Again, here you can see obstruction of the lacrimal sac and the filling defect that was in the lacrimal sac.
It looks like a stone.
Yeah, you are right. Stone or, as you mentioned, the calcified tumor or something like that. But what happened? We cannot see stone anymore, right?
Yeah.
Just after stent placement.
Well, you didn't extract it? You didn't take it out? No?
No, I didn't do anything. I just placed the stent like this.
Okay, I don't know.
Anyway.
Could it have been some sort of, well, okay, go ahead.
Yeah, here you can see. So I reviewed the case after stent placement. So we do stent placement under lateral view. So we advanced the ball tip guide wire through the punctum into the inferior meatus of the nasal cavity, and they pulled it out of the nails, and they introduced the dilator and sheath to place the stent. Here you can see the stone at the bottom, in the bottom of the dilated lacrimal sac, it was broken into fragment little by little during introduction of the sheath, and then the fragmented stone passed through the stent into the pharynx during injection of saline through the stent. So that's because I did not know where the stone passed. But anyway, the lacrimal stone is associated with chronic dacryocystitis in 10 to 30% of cases. So it is reported that it likely to be fragmented. And Jones reported 30 patients with lacrimal stones in 1965. 70% has partial obstruction and 30% had complete obstruction. He performed the surgical removal along with the dacryocyst or rhinostomy. So many doctors made the mistake because of they don't know about the dacryocyst lacrimal stone. So even though you are a surgeon, it's important to know the possibility of a stone in the lacrimal sac. That's why I prepared. Irelem from Germany, I taught him how to place the stent. I visited his hospital and gave a live demonstration. After that, he performed the lacrimal stent placement, and he reported his experience with the 10 patients with the lacrimal stones. He performed the balloon dilation to widen the nasolacrimal duct and to fragment the stones, followed by forceful saline irrigation in 2 patients, aspiration in 6 patients, and fragmentation in 2 patients. Here is an example. Here you can see peeling defect from the lacrimal sac to the nasolacrimal duct before balloon dilation. After balloon dilation, this is evacuated stone. And here is another case. Here you can see obstruction. And he used the Ambrose gooseneck snare to break the stone and then place the stent. Also, he injected the saline to flow the stone through the stent. This is case discussion. A 6-year-old female patient had a recurrent gastric cancer extending to the splenic flexure. Here you can see the obstruction of the small bowel, and then they performed endoscopic stent placement. Here you can see stent placement, and here you can see cancer at the splenic flexure. But this is a study 4 days after stent placement. This is a plain radiograph. This is an endoscopic photograph. Questions: what is the problem and how would you solve the problem? Manuel?
Okay. I think it seems to be collapse from the endoscopic pictures. I'm not sure if maybe a second placement of another stent would be necessary, or if dilatation with balloon might be useful.
Sophia?
Yes, I think it's collapse. Maybe I think about place another stent. I don't know if the balloon dilation will work.
You remember that I talked about the stent placement in the colon, right? Colon. And then actually this is collapse. The definition of collapse is different from incomplete expansion. Collapse usually means it expanded, but after growing of the tumor mass, it collapsed. So the definition is a little bit different, but there was no improvement because it did not expand. That means that there are 2 possibilities. The expansile power is less. And as you know, balloon dilation did not work effectively in patients with incomplete expansion in colonic stent placement. That's why we tried the balloon dilation, but it did not work effectively. You remember that, right?
Okay. Yes.
So anyway, this patient was reported to Department of Interventional Radiology. So anyway, this is 4 days after stent placement. Here you can see not completed expansion, and also this is endoscopic photograms 5 days after stent placement. So it was not possible for me to advance the coil catheter and guide wire because of there's a buckling here. Here you can see very, very tight stricture. That's why I introduced a small balloon catheter to dilate a little bit, and then it was possible to advance the coil catheter. Again, the coil catheter is very useful in this case. And then we introduced the dual stent here. Even after dual stent placement, there is also waist deformity, even though it is larger than the previous one. So I dilated with a small balloon catheter. But this is, you can see, 2 days after stent placement. You don't need to use a large balloon because it will expand to the preset expanded diameter within several days. But the patient needed to pass a stool. That's why we used the small size of balloon catheter. Okay, second case. 82-year-old male patient had vomiting for 5 days. The patient underwent distal gastrectomy when the gastrojejunostomy with jejuno-jejunostomy 5 months ago. So the clinician performed the contrast the study and endoscopic photogram, and also this patient was referred to interventional radiology for stent placement. Question: what would you do for this patient? Stent placement or further study? Andrea?
Andrea mentioned she's probably doing procedure, so she's listening, but probably she can't.
Oh, I see. Okay, okay. Manuel, what's your opinion?
Well, last time you mentioned that these cases, a CT scan is very useful to understand exactly the anatomy of what's going on. So maybe a CT scan would be good. But yeah, there's definitely some sort of problem with the gastrojejunostomy and maybe the afferent loop, I think. I'm not sure. But maybe I would do a CT scan to maybe know what.
Okay, okay. So, Sophia, you do endoscopy, right?
In our hospital, yes, we can do endoscopy.
Okay, would you please read these endoscopic images? What's your diagnosis?
I see, in the first one, I see like a mass, I think, like an obstruction. But then in the last one, I see a stricture.
Okay, this one. So yes. Can you tell which one is efferent and which one is efferent? Here you can see there are two loops, one and the other. There is also narrowing here, but there is no narrowing here. So which one is afferent?
Afferent, the other one.
You know that
one.
How do you know?
Because it has contrast.
Contrast, okay. And then actually this is anastomotic site. And so anastomotic site was okay. The endoscope passed through the anastomotic site. Before I performed stent placement, I called the clinician. What was your opinion about the anastomotic site? He said that we didn't know which one was that, but anyway, one loop showed the obstruction, so we could not pass an endoscopy through the one loop, but the other loop it was possible. But as you mentioned, this is a afferent loop. This is afferent loop. There is no stricture, but in the beginning of the efferent loop, there is a stricture, correct. So after this one, I asked another question. What kind of a procedure, surgery the patient had? The patient had, they said that the patient had jejuno-jejunostomy, which is very important. Jejuno-jejunostomy means probably the patient does not need stent because the afferent loop works, right? That's why, as Manuel mentioned, I said, no, I don't like the procedure. I need the abdominal CT to confirm the distal part because we have to check any obstruction of the small bowel or large bowel. Yeah, that was the answer. Fortunately, the abdominal CT showed the mass involving the transverse colon. This is ascending colon. It's also a simple cyst of the kidney. And also there is a peritoneal adhesion because peritoneal seedings. And then finally, we found out that the cause of vomiting was due to transverse colon cancer. So we placed a dual stent into the transverse colon, but it was good. Also, follow-up study shows a patent colonic stent placement, but the patient visited clinical department again 2 months after gastrojejunostomy stent placement because of recurrence of vomiting. Now you can see the contrast media study. At the time, the afferent loop was okay, but we cannot tell which one is afferent, which one is efferent. That means advancement into the anastomotic site. So my question, where would you place the stent? Or do you like to place the stent? Or what do you do? If you want to place the stent, do you like to place the stent in the afferent loop or efferent loop or in both loop? Manuel.
I'm sorry. Okay. I think that it should be placed, because seeing the diagram, it should be placed in the efferent loop, in the efferent anastomotic site, because of the jejuno-jejunostomy, the liquid will pass directly to the jejunostomy. To the jejunum, it will pass directly. So it won't come to the stomach, but it won't be obstructed either. So you won't have an afferent loop syndrome. So you need to be able to evacuate the stomach. That's the priority here. So you need to put one in the efferent. Yeah.
Okay. So here you can see a guide wire passing through the efferent loop and another guide wire passing through the afferent loop to meet each other at the jejuno-jejunostomy site. That's why we don't need to place the two stent. One stent is okay, but a little bit difficult to negotiate the afferent loop. That's why we placed the stent in the efferent loop, because the stricture was also more severe and efferent loop than the afferent loop. You can see two stents. So in patient with the recurrent cancer in surgically altered stomach, the exact information about the surgical procedure the patient had and the confirmation of the efferent and afferent loops are very important. Do you have time? Do you want me to show more cases, or do you want me to stop here?
So I have time. I'm okay today.
Today, Sophia?
Yes, me too.
Yeah, these are, we like cases. We're surgeons. We like cases.
Okay. This is a patient with subtotal gastrectomy with gastrojejunostomy 30 years ago. Remember, 30 years ago. That means a benign. But anyway, this patient died 5 days after stent placement because of recurrence of gastric cancer. What was wrong with the procedure in this patient? Sophia?
In the first image, I can't see the contrast. I think there was a mass.
Mm-hmm.
That was the place. And in the second one, I see the pass through the...
Yeah. This is before stent placement. This is after stent placement. Okay. So
I see the passage. I don't... maybe there was a migration or a perforation, something like that. I don't see anything but...
So here you can see, is this apparent or efferent?
I don't know. It looks like afferent maybe, but I don't think it's, I'm not sure. It looks like it's, looking at the position, it looks like afferent, I think, but I'm not sure. Because it seems like it's maybe, I don't know exactly what happened there. I don't know.
Yeah, you can see anyway, there is a cancer at the anastomotic site, and I don't know either. And this is afferent or efferent, but here are one loop and here is another loop, even though it is very faint. But anyway, the stent was placed in one loop by one of my colleagues. He was a fellow. Yeah. And then also it was easy to advance the whole catheter. So he placed the stent in the loop, but here you can see the patient died 5 days. This is a chest PA just before stent placement or at the time of stent placement. We routinely check the chest before and after stent placement. This is 5 days after stent placement. Here you can see aspiration pneumonia, right? Yeah. So the patient died of aspiration pneumonia. What happened? Because here you can see again, that was afferent, as Manuel mentioned. Usually afferent is on the right-hand side. If you look at it from the lateral view, it is posterior. So the stent was placed only in the afferent loop. Yeah. The patient did not have jejuno-jejunostomy. That's why there was an afferent loop syndrome after stent placement. It was a free passage of bile. And then the proximal end of the stent occluded the efferent loop, even though it was completely occluded. That's why there was aspiration pneumonia due to the reflux. This is very dangerous. So again, it's important to know exactly the clinical information the patient had, whether the patient had the jejuno-jejunostomy or without or with jejunostomy. Number 4, this patient with a subtotal gastrectomy with gastrojejunostomy 9 months ago, you can see this is a afferent loop. You can see this is a efferent loop, diffuse obstruction and short obstruction involving the afferent loop. And then 2 stent was placed because the patient didn't have jejuno-jejunostomy. Jaundice improved after stent placement, but with dysphagia to solid food. So after stent placement, the patient was able to have soft food, but not solid food. Why? This is a plain radiograph. This is a contrast study.
I can't understand exactly why, because if the stent is there and it's placed and he's eating soft food, he should be able to eat more solid food, but I don't understand that.
Maybe it was a bad placement, and the proximal and the both proximal end were at the same place. So it was a complete obstruction, but maybe I don't know.
Right.
Yeah, the both stents were like maybe clashing or hitting against each other, so they would like
Exactly.
the efferent would occlude the efferent.
Good
Yes.
point. Yeah. Also, here you can see good flow of contrast media, but contrast media is just a liquid.
Yeah.
So we asked the clinician to perform endoscopic examination. Here you can see endoscopy. And this is contrast study. Here you can see this is a afferent loop, but the proximal end of the afferent loop stent placed above the proximal end of the efferent loop stent. That's why it was possible to pass the endoscopy through the afferent loop here, but not through the efferent loop, because there is a proximal end that is bare stent. If it's a curved stent, not bare, this is a dual stent. This is a proximal end, which is bare. That's why soft food was possible, but not solid food, because the proximal end of the bare stent hindered the passage of solid food into the efferent loop. So we reported our experience with 5 different types of gastrojejunostomy, because it's important to know the procedure the patient had. There are 5 regarding the gastrojejunostomy. One is distal gastrectomy with gastrojejunostomy with no jejuno-jejunostomy, with jejuno-jejunostomy and the Roux-en-Y, and also this palliative stent placement. So you can see quite a lot of patients with no jejuno-jejunostomy. It's a surgeon's preference. Some surgeons don't like the jejuno-jejunostomy. But when the patient was reported to Assam Medical Center, there was no surgical data document regarding the jejuno-jejunostomy. So it was difficult for us to decide. And that's why we had to check the jejuno-jejunostomy or not. So it takes time. Like gallstone, dropped gallstone. So surgical note is very important.
Yeah.
And then we classified stent placement into 16 patterns on the basis of location of a stent. So there are 18 patterns in type 1. That means without jejuno-jejunostomy, and the type 4 in type 2 jejuno-jejunostomy, and type 1 in Roux-en-Y and the type 2. Anyway, you can say this is a complication. Pneumonia. You remember that this case. So when the patient didn't have a jejuno-jejunostomy, you should have to check either efferent or afferent on jejuno-jejunostomy site. Pneumonia occurred in this patient, and the pneumonia here. This is a misplacement. So this kind of parallel stent placement is important in dual stent placement, both loop stent placement. If you place the afferent loop stent above the efferent, it can occlude. But it is possible. For example, the other way is possible. You can place the efferent loop stent above the afferent loop stent, because it is just for passing the bile juice, right? So either way, you can place the proximal end of the efferent stent above the afferent loop stent or parallel, okay? And the last case, this patient had a total gastrectomy with the esophagojejunostomy 14 months ago. Here you can see recurrence at the jejunum, distal to the anastomotic spike. This is anastomosis. This is a proximal jejunum. So there is a recurrence. So we placed the esophageal stent. 5th generations of esophageal stent. That was a retrievable stent, but poor flow of contrast medium through the stent because the proximal end of the stent aborts. the jejunal wall. In addition, the patient complained of severe pain just after the stent placement. What would you do for this patient?
Because you have this option, because it's a covered stent, can you change the position of the stent? Can you move it?
Okay.
Is that an option?
Yes, that is option. But even though we place a longer stent, the patient can complain severe pain. But anyway, that is good idea. We can place a longer stent, but here you can see severe stricture. It can cause pain itself. Okay. Pain is from this part, not the aborting. Aborting causes the obstruction. This kind of severe collapse or stricture cause a complication like pain, like esophageal stent placement. When the patient had radiation fibrosis, the patient complained of severe pain. It is same. So, Sophia, any idea? So, longer stent is a good idea.
And maybe try to make a balloon dilation.
Balloon dilation, okay.
Because of the stricture. Because if you place another stent, the pain would be there.
Yeah, sure. Okay, good idea. Here you can see. We remove the stent because the patient complained of severe pain. And then the patient, we explained the possibility of placement of dual stent. As you know, the conformability of dual stent is much better than the covered stent. And then the patient accepted my suggestion and we placed the dual stent. But the disadvantage of dual stent is not retrievable one. But the patient didn't have any pain. So you can see the big difference between stent with conformability without conformability. So this is my last slide. As for the complications, stent migration occurred in 12% with fully covered stent and none in partially covered stent. On the other hand, severe pain occurred in 8% with a fully covered stent, but no pain in partially covered stent. So you can select. I'd like to use a retrievable stent, but sometimes it can cause pain. In the case, you can explain the possibility of unretrievability to the patient and the family.